Hi, my name is Sudarshan Parthasarathi. Everyone just calls me Sud for short. I'm a PGY3 resident here at Highland Hospital, and I'm excited to bring you a lecture talking about hypoxemia, and we're going to review some of the mechanisms and etiologies. It's important to know about hypoxemia because this is a commonly tested subject on the boards, and it'll be very important for you as an incoming intern. The objectives of my talk will be, again, to review the mechanisms of hypoxemia. I'll use a couple of diagrams as well as a couple important equations, and then give you a systematic approach to differential diagnosis of hypoxemia. So, to start, it's important to make sure we understand that hypoxemia and hypoxia are not synonymous. Hypoxemia is defined as a decrease in the partial pressure of oxygen in the blood, whereas hypoxia is defined by a reduced level of tissue oxygenation. It can be due to either defective delivery or defective utilization of oxygen by the tissues. Hypoxemia and hypoxia do not always coexist. You can have hypoxemia without hypoxia if you have a compensatory increase in hemoglobin level or cardiac output. Similarly, you can have hypoxia without hypoxemia. A common example is cyanide poisoning. Here, your cells are unable to utilize oxygen despite having normal blood and tissue oxygen levels. So, let's proceed and go through a couple important equations. One is the AA gradient. So the AA gradient here measures the mean alveolar oxygen pressure, and you subtract that from the arterial oxygen tension, and this is measured in an ABG. How do you derive the mean alveolar oxygen pressure? Well, you use the alveolar gas equation. So the mean alveolar oxygen pressure is equal to the fractional concentration of inspired oxygen, that's FiO2. This is usually about 0.21 at room air. You multiply this by the barometric pressure. This is 760 millimeters of mercury at sea level. And you subtract the water vapor, and this is usually about 47 millimeters of mercury. Now you take that entire term and you subtract the arterial carbon dioxide tension, and this is usually about 40. And this is divided by the respiratory quotient, which is about 0.8. This can vary with metabolism, but it's usually about 0.8, and it only really gets affected when you have a very extreme diet. Now, before proceeding, what I like to do is rearrange this formula so that I have my arterial oxygen here, and then I have my alveolar gas equation subtracted from my AA gradient. And the reason I do that is so that I can elucidate some of the mechanisms really clearly by just thinking about if I perturb one value or the other. So the first one to start with is the barometric pressure. Now, this is what happens when you go to high altitude. This is not a very common clinical scenario, but essentially, if you went to Mount Everest and you went to base camp, for example, at 19,000 feet, your barometric pressure is going to be 380 millimeters of mercury. So you're obviously going to get some level of hypoxemia. This is not very clinically relevant, so I won't discuss it much further. The next one that's important, though, is anything that raises your arterial carbon dioxide tension, and that is commonly seen in hypoventilation. The big three things that I think about here are drugs, such as narcotics. I think of obesity, and I think of any CNS disorder that could impair my central drive. And finally, and the big one that we'll spend the majority of our time talking about, is the AA gradient. And that comes from these three mechanisms. So VQ mismatch, right to left shunt, and diffusion impairments. All of these three have an increased AA gradient. Now, first of all, what is a normal AA gradient? For a young non-smoker, it's usually between 5 and 10. But as you age, this increases. And one formula that people use, and it's a rough one, is to take the age over 4 plus 4 as a measure of AA gradient. Now, to further tease this out, only one of these mechanisms of hypoxemia don't respond to giving supplemental oxygen, and that's the right to left shunt. I'm going to go ahead and kind of explain that with a simple diagram here. Now, in thinking about shunts, think of this is an alveolus, and this is a simple capillary, and this is where gas gets exchanged. So this is mixed venous blood, this is arterial blood, and this is room air coming in. So normal values here are PO2 is usually about 150, PCO2 is about 0. As you breathe in your alveolus, your PaO2 is going to be about 100, and your PaCO2 is going to be about 40. And here in the mixed venous side, venous blood, your O2 is going to be about 40, and your CO2 is going to be about 46. And so as blood travels along, it's going to equilibrate, and you're going to get oxygenated blood here at the arterial level. And usually your arterial O2 is going to be about 95, and your arterial CO2 is going to be about 40. That is a normal gas exchange. Now, in the example of a shunt, so this is an extreme kind of position where you're having a lot of perfusion but no ventilation. This is an extreme example. What you're going to get is, this is normal physiology, so you would expect on the arterial side your PaO2 to be 95 and your PaCO2 to be about 40. But here, since you can't participate in any ventilation because of the shunt going on here, you're only mixing with deoxygenated blood. You never mix with room air here. So at this point, you're going to get an admixture of blood from shunted side to non-shunted side, and it looks like basically you don't get enough oxygen. So your PaO2 resulting as an admixture is going to be like 60, and your PaCO2 is going to be about 40. And it's important to think about this because now imagine if you gave 100% FiO2. Now your PaO2 here, or PO2 here, is going to be like 700, and your PCO2 will be 0. And this will kind of move down the normal side of the lung, and your PaO2 will be about 600, and your PaCO2 will be about 40. And here you'll mix normally. But on this side, again, because you have a shunt, you can't basically ventilate this part of the alveolar capillary unit. So again, you're going to have a low PaO2 coming from this admixture. And this admixture will give you just a little bit better because you're at 100% FiO2, but you're still hypoxemic. Maybe you might come up to 70 or 75 now, and your PaCO2 will be about 40. So this is why in just the shunt case, basically giving FiO2 100% will not correct the degree of hypoxemia. However, this will happen with all the other etiologies. So since this is a very brief discussion, I'll just kind of come back to my general and final approach. So first ask yourself, is there an AA gradient when I think about mechanisms of hypoxemia? If it's normal, then I want to think about hypoventilation. And again, remember drugs, think narcotics, think CNS disorders, and think obesity. Or think high altitude or low inspired O2. Then if it's elevated, I want to think about my other mechanisms. The first thing is I ask, is there a good response to supplemental oxygen? If there is not, then I'm going to think about my right to left shunt. And in this case, I have to explore other etiologies of my hypoxemia. Maybe I need to get a TTE and get a bubble study and see if I can elucidate where the shunt is happening and how important physiologically it is. If I do get a good response, then I'm thinking a VQ mismatch, which is the most common cause of hypoxemia that I'm going to see. This is what you're going to see in your pneumonias, your PEs, but all of these etiologies that we talk about are kind of mixed in picture, so I'm not going to put them into one particular category. And finally, we can think of impaired diffusion. That's the last category of hypoxemia. In this case, we want to measure a DLCO and get a chest X-ray and a CT scan to think about etiologies such as pulmonary fibrosis or interstitial lung disease. So I think if you are able to do this, check your AA gradient, see if it's normal or elevated, you can figure out the different etiologies of hypoxemia. And remember, if you don't respond to supplemental oxygen, you think about a right to left shunt. If you do, you think about VQ mismatches and impaired diffusion, and then proceed from there. Okay, I hope you come back for further podcasts here.